Got it. Okay, here we go. So I see that we're now live. Welcome, everyone. Great to have you here. I am really honored today to have Dr. Hans Frykman, MD, PhD, who is a real expert on these tests, p-tau. We're going to talk about p-tau 217 today, neurofilament light, and GFAP, probably the best biomarkers available. Rarely I have to say, rarely in my entire career has there been a time when there is a new development that has such important practical potential for all of us. So, for example, being able now to look when people are pre-symptomatic and say, okay, you are headed for Alzheimer's disease and you never have to get there. This is a huge development from just a few years ago where people said there's nothing you can do about this. Years ago, we went from type 2 diabetes to, okay, now we can detect pre-diabetes. And of course, now we can detect insulin sensitivity, and it makes a huge difference. And the same thing is now happening with Alzheimer's disease. We're rapidly getting to a point where Alzheimer's disease is going to be optional. You can check early, you can find out if you've got the very changes that Dr. Frykman is going to talk about today, and then you can do something about it. You can get on reversal of cognitive decline and protocol, and really we should be able to have a huge impact on the global burden of dementia. So Hans, great to have you here today. Thank you so much for joining us.
Thanks, Dale. It's my pleasure, really. And thanks, everybody, for listening to us. I'm a clinical pathologist of training, specializing in neuroimmunology and neurochemistry, and in the neurochemistry field, particularly around the area of neurodegeneration. So this is what I like to talk about, and let's get going.
Yeah, so and just before I want to show a couple slides, but before we do that, I wanted to tell a little bit of background. How did you get interested in these specific biomarkers?
Well, I mean, I followed them for the longest time. So there was a test using spinal fluid that has been around for around 10 years in Europe specifically, and other parts of the world, not so much in the United States. This test is very good, but it does demand that you do a spinal tap, which is a very uncomfortable, to say the least, procedure, both for the
Yep,
doctor and the patient.
I've done hundreds of them.
And then, but things started to happen in 2017 regarding the blood-based biomarkers. In 2018,
Yeah.
there was publications, one from a Japanese group, and then in 2020 there was the publication that changed everybody's mind. And that time we also got our first instrument in early 2020, and then we got our first pharma trial, and the rest is kind of history. We were doing very well. We were very sincere and from the start on being the best lab in at least in North America in this field. So the most complete as well. So we are doing both spinal fluid testing as well as blood-based testing.
Great. Okay, so I'm going to just show a couple of slides here because I think there are some good things to illustrate. So let me share this, and just so people can see why we are so interested in this important test. So first thing to say, that what we've put together is BrainScan, and this is in collaboration, of course, with you and with your expertise, is the idea that you can now take a simple blood test, as you said, and you can look at 3 different parameters, and these are very much complementary parameters. And so this is what's going to take us to that next level where virtually everyone can avoid Alzheimer's disease. And we'll talk about when to do that, why to do that, et cetera. But I think it's important to point out that the test that you have developed is more sensitive than what is available elsewhere. There are a couple places you can get p-tau 217. Those are not positive in the pre-symptomatic state, but yours is, and that's a huge difference for all of us who want to avoid the cognitive decline. So what we call BrainScan, this triad of tests, includes your p-tau 217 test, which is a specific biomarker for Alzheimer-related processes. So we often talk about synaptoblastic signaling, synaptoclastic signaling. When you are pulling back, you are phosphorylating your tau. And if this is related to Alzheimer's, your p-tau 217 goes up. Neurofilament light is related to neuronal damage, so quite much less specific, but tells you that there's a problem with neurons. So it can be increased, for example, in things like frontotemporal dementia, ALS, things like that. And finally, GFAP, glial fibrillary acidic protein, which is complementary because now that's outside the neuron, that's in your glial cells, specifically your astroglial cells. So it's a biomarker for ongoing inflammation and repair. What's nice about GFAP is that it is an early marker. So Hans, if you could talk a little bit about how you chose, or where these markers are actually coming from in the brain. It's kind of remarkable that you can get a blood test that really peers into your brain.
It is, because we had to look through all of these biomarkers almost that you see on this slide, and do lots of research. And finally, we settled on 3 biomarkers of being superior or giving more information than the others. Not saying that the others can't be used in clinical trials and such, but for practical use, these are the 3 biomarkers. And the p-tau 217 is the outstanding biomarker because it's 95% in our assays, 95% accurate in predicting amyloid pathology, which is these plaques that you see at the end here. Those plaques, that when they form, they give rise to this phosphorylation of tau, which is closer to the cell nucleus here. What happens then is that p-tau forms, and that can be detected in blood in very, very small quantities. And for that, to measure that, you have to have particular instrumentation that is very complex and advanced. In addition to that, we can measure NFL, which is more, it comes from a different site, as you see here. It's kind of on the axon, which is part of the neuron. And then GFAP, as you mentioned, is from a completely different site, the astroglial cells. So this is a biomarker that we think about it as inflammation, but there's also been publications showing that perhaps this inflammation is the first thing that happens. And I think you're quite a fan of that theory and knowledge. And so this can show up as the first thing that happens, but it's more of an all-cause dementia biomarker, whereas p-tau should be seen as a very specific biomarker for these plaques down here. And then NFL is more of a biomarker for general problems in the brain that is of more severe nature.
Great point. And so I just wanted to add for everybody, because people have said, well, look, I don't want to check mine because if I'm high, then I'm really worried. Please do not worry. That was the old way of thinking. It's a little bit like saying, if I find that my fasting insulin is high, do I have type 2 diabetes? Well, you might have it in 10 or 15 years, but you're at that beginning time, which is why we want to find it and prevent you from ever getting type 2 diabetes with all of its complications. If your p-tau or GFAP have begun to drift up, please don't worry. We will get you on an active and optimal program so that you don't have to have further problems. And by the way, that's the other thing I love about p-tau 217. As you've pointed out, it goes up over the course. So if you're doing well, you can actually use this to follow your stage, to follow you as you do better. And you can also use it to help direct, are you doing the right things? So yeah, this is something, of course, we've talked about many times, but I think it's important for people to see this. There are changes in the brain a long period of time. So Hans, if you could talk a little bit about these biomarker changes and how long they
are. So this is a remarkable study that was published in New England Journal of Medicine, which is the most prestigious medical journal there is, and they hardly ever published anything about biomarkers in the brain, but this was well worth that publication. And what it shows is a huge Chinese study out of Beijing, where they did spinal tapping of people that were healthy at day 0. So they recruited 45 to 65-year-olds back in 2000, and then the study concluded in 2020. And they would tap them every 2 years, both the healthy people and the people that were cognitively declining,
Mhm.
and then do also the assessment of their cognitive aspect. So what happens in here is that you can measure this all the way back almost 20 years, 18 years before you see the diagnosis. You will have the difference in the biomarkers. And if you look at this, you can say this is possible from a group level, from a individual level. Maybe this is not going to be possible because you're going to have variations, etc. But from a group level, you could see this 18 years before. It's just stunning research. And we thank all the people that participated in this trial and the authors of the trial. The thing, though, to mark out here is that this spinal fluid, A beta 42, that they measured here correlates almost perfectly with p-tau 217. So if you're looking for the biomarker in blood, 217 is the one that you're looking at for similar results to this.
Yeah, I think this is such an important point that we now understand that these biochemical changes go on a long time before a diagnosis of Alzheimer's. And I should mention in that same paper, of course, they actually noticed some changes in cognition about 6 years before a diagnosis of Alzheimer's. So again, it comes back to the fact that people have been diagnosing Alzheimer's way, way too late. We can do much, much better. And this is why I think there's going to be such an important role for p-tau 217, and specifically the highly sensitive one that you are running and that other labs are not running, which is picking things up before you get symptoms and really allowing us to prevent the problem. And so I should mention, this is not your routine run-of-the-mill blood test. These are highly sensitive. And so, Hans, maybe you could comment on these instruments.
Yeah, that's a good point. So we have several instruments in our lab. Here are two of them that we use quite a bit. And one, we have the 217 on both, actually, instruments. But other providers only have the Lumnipulse, for example, which is an assay that is sufficient to pick up mild dementia, but not sufficient to pick up the Alzheimer's changes, or sorry, the amyloid changes before disease starts to present itself. So before memory loss starts. So our assay, which we use the ALZpath p-tau 217, is the most sensitive assay currently, and there are lots of publications confirming that, and we are the only lab providing this assay in the world, I think.
Yeah, it's a good point. I mean, this is going to do for Alzheimer's, what fasting insulin did for diabetes, what Pap smears did for cervical cancer, what chest X-rays did for picking up early nodules in the lung. I mean, this is going to really, really change the landscape. We also know from our own protocols that people who are in the earliest changes do extremely well. And then people, as you get in the very, very late stage where you have single-digit MoCA scores, we can see some improvement, but it's typically not all the way back. And so we can do much, much better if you come in early. And if you come in when you're asymptomatic, you have a virtually guarantee to do very, very well. So very enthusiastic about that. So Hans, if you could comment on this a little bit, it really shows the dramatic difference and how beautifully this test correlates with the actual neuropathology. So it's really telling you that it's looking at the brain.
This is a neuropathology cohort from the University of British Columbia, where I'm also a faculty member. These were patients that were collected serum before they passed away, and this is post-mortem neuropathology and correlation of that to their and what we can see here is that there's a big difference between Alzheimer's dementia and Alzheimer's dementia. So this biomarker should be seen as a specific biomarker for Alzheimer's type of dementia. So Alzheimer's type of dementia is around 62% of all dementias. Yeah. There are three other common types of dementias, but Alzheimer's is the most common one. And in this, especially the Alzheimer, the first one, which is the B, you can see quite a distinct difference between the non-Alzheimer's dementia and the Alzheimer's dementia with mixed and without mixed pathology. So the one that is more to the right is the without mixed pathology, the pure Alzheimer's.
Yeah.
And then when you go to the Fuji-Ribio assay, which can distinguish this, but more on a group level, not as well on an individual level. So again, it's better in the case of without mixed pathology or the pure Alzheimer's. While there is quite a bit of overlap when you have a mixed pathology.
Yeah.
You can go to the next slide, I think.
Yeah. Yeah, actually, this is actually going to be the requirements for the brain scanning here.
Oh, I see. Okay.
So,
Yeah. So I wanted to say also that the NIH and collaborating universities have seen this data and chose the ALS path for the large NIH-funded primary care prospective study. So this is a big deal because now they're going to use this blood test to identify people that are going to get disease-modifying treatment, in this case, the new drug lecanemab.
yeah.
And they're doing concomitant using our ALSPath p-tau217 together with PET scans. But the purpose of the trial is to show that the ALSPath p-tau217 is so good that you can detect MCI and give them lifestyle advice and coaching. And for the people that have mild Alzheimer's, they can get lecanemab. And so this once again shows that when given the choice, these top researchers shows the ALSPath assay from our lab, and we're performing all the testing for all of those trials. There are several of them going on, and they're going to go national here later in the year.
Okay. Yeah. So I think it's important to point out that if you have an intermediate value here, there is a concern, are there other pathologies, not just the beginning of Alzheimer's? And as far as lecanemab, of course, we can do far better than lecanemab. But I understand that, that there's a desire to use these antibodies, and they may be helpful in the long run to remove some amyloid as well. So I think it's important, again, we want to be very practical about why we think this is so important and how it can be helpful. For anyone who's 30 or over, you can get this test. This is the only place you'll be able to get it direct to consumer, as far as I know. And you can get it through Get a Brain. If you just go to getabrainscan.com. If you're under 30, it does make sense to get it if there is a family history of familial Alzheimer's. Now, that's only typically less than 5%, but if you have relatives who've had either APP mutation, presenilin 1 or presenilin 2, or have developed symptoms in their 30s or 40s, then it's a good idea to think about it early on just to get things started. For others who haven't had those mutations and haven't had any in very young relatives, then I would certainly wait till you're 30 or over. I usually recommend people as they turn 40 to get evaluated, get on active prevention so you can make this a rare problem. So as far as what to actually do, what's the practical step? First of all, to get these labs, I'm going to get them myself. They're going to be available in the next couple of weeks. So I will be getting these myself. I want to see where things stand, because they really give you three very complementary pieces of information and actually a nice report to kind of summarize them for you and say, here's the implication of these things. If your risk is intermediate or high, please get on Recode, because this has been what's worked best so far in terms of actually improving people. If you have a low risk, take the CQ test, see if you're doing well. We just talked to a guy a couple of days ago who said he thought he was doing fine, but he just was starting to have a little trouble with finding words. He already had a very, very positive amyloid PET scan. So anyone with a positive amyloid PET scan would be positive on p-tau217. So again, you don't have to get the PET scans and the spinal fluids anymore. You'll be able to get this with this nice test. And then sign up for whichever program, get on Recode for treatment, get on Precode. Precode is for prevention. So if you're really totally negative, The CQ is normal. You're relatively young. Fine, get on prevention. We really want to make it so that nobody ends up with significant Alzheimer's. Nobody ends up in a nursing home. So I want to just show a couple of examples here and ask for your comments on this. So Hans, here's a person who has high p-tau, high GFAP, and a slightly high neurofilament light. This is, as I understand it, basically someone who has relatively active Alzheimer's. But again, please do not worry. We see again and again and again people improving. And this is a schematic, of course. And Hans, is that the sort of thing you would suggest with this sort of test where all three of them are high?
Yeah, so the NFL wouldn't be so high in Alzheimer's, pure Alzheimer's. If you have
Okay,
GFAP can be high or not, depending on how much of the inflammatory component you have
right.
and exactly when you measure it. So this can be a little bit, but the p-tau 217 definitely would be high. And so this is a picture of somebody who has pretty active disease, just like you pointed out, with quite a strong inflammatory component
Yeah.
to their disease.
And you bring up a really good point. So years ago, we described multiple subtypes of Alzheimer's, and some of them are highly inflammatory, and some of them are non-inflammatory. They're more atrophic or toxic. So you're absolutely right. You would think from this sort of schematic, this would be a person who indeed has some inflammation that's ongoing in the brain. And so you make a good point. The NFL is a little high. It's possible this person has mixed pathology. If something is obviously disturbing this person's neurons, but I wanted to show these different examples so that people could get an idea. So here's someone who has a clearly high p-tau 217, but a normal GFAP and a normal NFL. And Hans, if you could comment, so what would be your reading for someone who has this sort of result?
This is probably very early on, and person could be perhaps even asymptomatic here. Or it's MCI, which is
Yeah,
the very early stage. So I think we're looking at where the biomarker p-tau 217 is extremely useful because it's
right.
early and it's accurate. It's very, very accurate, 95% accurate.
Yeah, great point. Okay, so here's another example where now someone has a normal p-tau 217, but has an abnormal GFAP and a normal neurofilament light. So maybe you could talk a little bit about this because this is something that certainly we anticipate you're going to see this because, as you indicated earlier, GFAP is quite sensitive. It's not specific, but it's quite sensitive. So here's someone who doesn't have Alzheimer's, but could be headed for it down the road or has other things causing inflammation in the brain.
Exactly. So we see this post-COVID, for example, this
Yeah,
kind of GFAP, very, very high. So we see lots of demand for all these long COVID cases that have brain fog, and they have this GFAP quite elevated. And GFAP then becomes a biomarker for all-cause dementia. So there are big studies been done where GFAP not so specific to Alzheimer's, but it's very specific to dementia
yeah.
as a group of diseases.
Yeah, great point. And so in the people who have brain fog associated with COVID and especially long COVID, do you see a normal NFL or do you see a high NFL?
No, mostly normal. So I think the or slightly high, but GFAP is the one that sticks out. Sometimes p-tau 217 starts to come up even in patients that are very young, which is disturbing, honestly.
You bring up such a good point because people have talked about this again and again and again. There's already been epidemiological publications showing that people who have had COVID-19 are at increased risk for Alzheimer's disease.
Yep.
Furthermore, we know that some of the pathophysiology is similar with the activation of the innate immune system, often with the ineffective activation of the adaptive system. So this is playing right into the hands of Alzheimer's disease. And
Mhm.
again, another reason, if you've got COVID-related brain fog, this could be the first step in down the road Alzheimer's. Please get it checked out. Please get evaluated. Please get on an optimal program so that you never do progress all the way to dementia. All right, then here's the last of the four examples. So here's someone, again, normal p-tau, but now this person has something going on. You can see high GFAP, so indicating some inflammation and some regeneration potential. And neurofilament light is now high as well. So maybe talk a little bit about the implications here.
Yeah, so what we can say with quite high certainty, is that this is not a Alzheimer's type dementia. This is rather something, this is in keeping with something that's called FTD, or frontal lobe dementia. And we have Bruce Willis, who is a prime example of a patient that has come out and said that he has FTDs, is a more sinister type of dementia. But even here, I think you have some help to be given, right?
Yeah, and unfortunately, fortunately, this is a relatively uncommon
Yes.
disease. But as you mentioned, Bruce Willis just came out not too long ago, and of course, Wendy Williams just came out a few weeks ago, and
Oh,
and indicated that she had developed frontotemporal dementia as well. So again, we want to get in as early as possible to try to help. So here's again an example where a blood test can be very helpful. Now, one other thing, I know that GFAP has been pointed out to be a very striking marker in prion diseases. So someone, for example, who's developing Creutzfeldt-Jakob. Now that's uncommon. That's about 1 in a million people. But there's some concern, and there's been some increase in an area of Michigan for unclear reasons why these prion diseases can increase. With the prion diseases, do you see a high NFL or do you see a normal NFL?
that's a good question. I think the NFL, the GFAP definitely is high. The NFL can also be high, depending how far along we are. So I think it goes up with the disease. So.
Gotcha. Okay, so we'll finish up. Then we're going to take some questions. Let's start with the frequently asked questions. So first thing people say, I'm scared to get these, what if the results aren't good? Such an important point. And as I say to everybody, please do not worry. We are in the first era where there is a tremendous amount that can be done. And like every other chronic disease, the earlier you start, the better the outcomes. This is why I'm so excited about the fact that Dr. Frykman's test will actually pick up the p-tau even when you're asymptomatic. That is so important because now you can avoid the problems. So very helpful. Next one is here. It says, I'm currently on Recode or Precode. Do I need to take this lab? It's a great point. And here's the difference. What these what p-tau, GFAP, and NFL are telling you is whether you have the changes. What the labs that Recode have been done over the years tell you why you have it. So do you have inflammation? Do you have methylation problems? Do you have detox issues? So you want to have both. These are very much complementary. These new tests are telling you if your brain has the pathophysiology ongoing, which is so critical to know. The other labs would tell you why that is, what are the things that you need to address to get the best improvements. When will it be available? You can see here mid to late May, so it's coming. I'm looking forward very much to having my blood drawn and seeing where I stand. How much will it cost? For the first 90 days, it'll be offered at a discounted price of about $620, and that's for all three tests and for the report altogether. And again, the fact that this is the most sensitive one available, that it is the one that's showing pre-symptomatic changes, makes all the difference in the world in terms of avoiding the problem. You can see here, there's a QR code you can scan here so that you can get on and get these available. Now, let me go ahead and take some questions here. And let's see. So this is, here we go. Okay, so from Rochelle is saying, thank you for this. How does one access this test in Australia? So Hans, when will this be available in Australia?
We're not talking to anybody in Australia currently, but if you have a lab there that would be interested, we're happy to start talking to them. We are discussing with labs all over the world almost, but not Australia just yet.
Well, so hopefully we'll be able to help. And when we first started doing the training for Recode, I have to say the most Ahead of the curve group was the group of physicians from Australia. So great fondness for all that, the team there. There's so many good people there that are they're doing such good work. So let's do everything we can to push that forward so that people can get it in Australia as well. Now, Jane says, does triggering a p-tau plasma marker mean definite conversion to AD at some point? I mean, that's the whole point of our work over years and years. No, and now let's back up for 1 second. When you say Alzheimer's disease, people often misunderstand and they think that you mean Alzheimer's related dementia. Alzheimer's disease is a pathology, just as Hans was showing with these tests. It means you've got some plaques and tangles going on. It doesn't necessarily mean you will ever get dementia. And in fact, there are centenarians who die with normal cognition, who, when you look at their pathology, they'll have, quote, Alzheimer's disease. So let's remember there are 4 stages. There's the pre-symptomatic stage of Alzheimer's. You've got some plaques and tangles, but you're doing just fine. Then you have the SCI, subjective cognitive impairment. By definition, that means that you can score normally on cognitive tests, but you begin to notice, I'm not quite remembering some of the words. I might be forgetting some names. So many of us go through this. And again, this is something that we can be helpful. And you can now look and say, okay, am I on my way so that I can prevent getting full-on Alzheimer-related dementia? The third of 4 stages is MCI, mild cognitive impairment. By definition, your scores now are not normal on cognitive testing, but you still have your activities of daily living. You can still take care of yourself, you can still drive, and you can still balance your checkbook, stuff like that. When you're now losing your activities of daily living, by definition, that's dementia. And people often equate that with Alzheimer's, but Alzheimer's is really the pathology. These are all stages of Alzheimer's. So we want to get in early. Now, so triggering this plasma biomarker does not mean you're going to convert to dementia at some point. And that's exactly what our trials have shown. So it was a research trial, didn't pursue, but you qualified. Okay, so please don't worry. If you qualified for the research trial and your tau is high, please get on active treatment. You should absolutely do recode instead of precode, as you're mentioning here, because we want to bring your tau down. And by the way, we're already beginning to see some taus come down in the current trial. I think it's going to be a very good marker. If you've got an abnormal, get on treatment. You can recheck it again. Hans, do you recommend 6 to 12 months or so, or when do you like to recheck if someone is on treatment?
Yes, that's correct. So 6 to 12 months, I think, for somebody who is very ambitious, you could even think about checking it after 3 or 4 months, but that means that you do everything and very intensely. But most people, I would say 6 months is good.
Yeah. Again, I think this is one of the best things about this test. You not only can use it as a marker for before you get dementia, but you can also use it as a follow-up. So if you're high, you can get on the right appropriate testing, and then you can get on the appropriate treatment and then recheck it. So we recommend, if it's completely normal and you're asymptomatic, check it at 35, 40, 45, 50. Once you hit 50, do it every couple of years if it's normal. Once it becomes abnormal, if it does, please don't worry. Get on treatment, bring it right, and you can now use it to follow as you're coming. Use it just as you use your cognitive markers. It provides another very objective look at what's going on inside your brain. Now, let's see. She says she scores very high in cognitive testing. Great. No brain volume. Fine. This is great. But again, what you're seeing is the earliest stages of this change. It's what you're describing here with an abnormal tau, but normal cognitive testing, very much analogous to someone who has pre-diabetes or even just insulin resistance, pre-diabetes. So again, don't worry. This is something that's very treatable, and you should go ahead and get treated. Next one here is from Patrick. Beta amyloid 42 to 40 ratio. I'm so glad you brought that up. So Hans, we haven't talked today about the 42 to 40 ratio, and I think you have some very important things to say about that.
Yeah, so that's absolutely the best biomarker in spinal fluid, and
Spinal fluid, yeah,
the easiest to understand. It's not appropriate to do it in blood, although there is a large lab company in the United States that started offering that test about a year ago, but I think they have retracted that test now and replaced it with a p-tau 217. It's not a suitable test for blood testing, and everybody knows that in these communities.
And you know, one of the things that I thought was most important that you showed, when you have a p-tau that's abnormal, it goes up, as you pointed out, about sixfold from normal. So you have a tremendous dynamic range. When your 42 to 40 ratio is abnormal, it's about what, 10% lower or something like that?
Yeah, that's right. So
It's
within
almost normal.
within the error of the
Yeah.
test, so it's
So
not useful. That's why. So that
exactly.
there is peripheral production of A beta 42, so that makes it impossible to measure because beta 42 goes down in CSF.
Yeah. So
The
now
production of
Nora is
beta
asking.
42 increase and then it gets consumed, so then it
Yeah.
actually goes down. So.
Yeah, so it's really not a great test. That's the problem. That's why it's not included in that triad. Next one is Nora. Said I had chronic Lyme for many years. Do you recommend this gets this test based on my Lyme diagnosis and damaging effects it has on the brain? Such a good point. Thank you, Nora, for making that point. Absolutely. And you may have seen a wonderful documentary, which is all about chronic Lyme disease, which is called The Quiet Epidemic. If you haven't seen it, I think it's streaming on Amazon. If you haven't seen it, please take a look at it. And it's the controversy about the nature of chronic Lyme disease. And there's no question, people have the same sorts of changes in terms of ongoing inflammation in the brain that can lead to problems down the road. So absolutely would recommend you get that. And you may find that your GFAP is very high. And again, you can follow these things as you get optimally treated. Patrick asks about 217 versus 181. And as you pointed out, 217 is actually a better test. So Hans, if you could talk a little bit about that.
Yeah, so the difference between people that have disease and non-disease is much better. So the
Exactly. So
overlap
yeah, so
between
again, the p-tau 217 has been written about extensively as more sensitive and more
yeah.
accurate than the 181. So this is why we recommend people get the 217. And the next one is asking about how were reference ranges determined for these, and are there optimal ranges that the conventional labs fail to show that either you have an opinion about? And I know, Hans, this has been an area where you are a real expert, where you've really looked carefully. You've looked at the pathology, you looked at the correlation with Brock stages, you looked at the correlation with CIRAD stages. So you've really done a tremendous job at absolutely getting those correct ratios, and I mean the correct
Yeah, exactly.
numbers
So that's a very important to point
ranges.
out. So in our lab, we did validation work of 2,000 patients, out of which all of them were PET confirmed, and 400 were PET confirmed healthy controls, meaning that they are completely cognitively healthy that did PET scans. And then we got their plasma. So the other labs in the United States haven't done any of that kind of work, and that's why NIH and all those universities have chosen us for these big studies coming out now.
Yeah,
This is really the background of all that. So, and this was all done on the ALSPAT assay as well. So while we have two assays for p-tau 217, we promote the ALSPAT 217 in this case because of its superior sensitivity.
yeah. Next one says, can these components go up individually in other diseases? So it's just what we were talking about before. The p-tau 217 is specific for Alzheimer's disease related signaling. It doesn't mean you have late stage Alzheimer's. It just means you've started to have that signaling. The GFAP, as Hans pointed out, it's a different cell. It's coming from your astroglial cell, which gets activated when you have inflammation, when you're trying to do repair. It's activated in many things. So it's very sensitive, but non-specific. You could have had a prion disease, you could have vascular disease, you could have trauma, all sorts of things can increase your GFAP. And as Hans was talking about, people who have COVID with brain fog can see an increase. And then again, a third complementary test, the NFL, is really telling you that there's neuronal damage. Frontotemporal dementia is the classic one that shows that. ALS shows that, things like that. So these are all giving you different information. Robin is saying p-tau 217 declines while on recode. Will you be able to see cognitive improvements quickly or over time? Great point. And I think it is important, and Dr. Frykman has pointed out, this is not like getting penicillin for pneumococcal pneumonia. This has been, remember, this has been something that's been ongoing for years. So think about a train going 100 miles an hour. The first thing that's going to do, it's going to start slowing down as you do the right things. Slowly, slowly, it'll grind to a stop. Now it can start going backwards, backwards, backwards. So the point is that that's what's going on with Alzheimer's. It takes some time to stop the ongoing process. So we do see, and then we'll know much more when we complete the current trial. But yes, we expect that as people's p-tau is going down, they're improving. But it's going to take some months. As Dr. Frykman said, 6 to 12 months, good time to look. And good to do it after you've gotten the person on the right things. You're seeing cognitive improvement. Recheck it to make sure. It's going to help us guide to say, aha, this program is not working so well for this person. This program is working very well for this person. So it will really help to guide us to get the best cognitive outcomes. And then let's see. Can my doctor request this test? Will Medi-Cal pay for this test? So this is currently you can get this direct to consumer. What about, so Hans, what if the doctor wants to order this?
Yeah, so they can order it, and we'll help them get that. We have phlebotomy all over the country, and so they can contact us. I work at Neurocode Labs, so it's www.neurocode.com is the lab that I work at, and you can contact us there, and we'll help you get all these tests through your doctor if needed. There are some questions regarding the payments and that if LabCorp or Quest would offer these for free, and obviously they are very capitalistic companies, so that's not going to happen. When they say that the test is covered, it means that a small portion of the test is covered, but you will be liable for most of the test cost anyway, one way or the other. So what we see right now is that the $20 is covered by the insurance or something like that. So we can make that happen for you as well to file with insurance. But honestly, I don't think it's worth it at this early stage. Later on, we will probably have this all covered by insurance, but not for people that don't have already quite severe memory difficulties. So for everybody who wants to take this test because they're concerned that they start to have pathology in their brain and their memory is fine, we can do the test now. This will never be covered by insurance.
Yeah,
I think it's important to point out as well that insurance is not going to cover that kind of situation, right? So.
yeah. So I think it is important to point out some key points here. Number one, the tests available from Quest and LabCorp currently are not as sensitive as what you are offering. They don't show abnormalities in the pre-symptomatic stage. Number two, when they say they're covered, that's a tiny piece of them. You're still going to be required to pay most of it. Number three, you can't get those direct to consumer. You're going to have to get your doctor. So you're going to have to pay your doctor for a doctor visit as well. And number four, yes, putting something into this to get a result is going to help you to stay away from assisted living, senior care, things like this. So these can potentially be life-saving tests. Very, very important to recognize. This can really help you. Next one here is again about how do you get it in Australia. This is from Paul, and it's not currently available in Australia. I certainly hope it will be in the coming years and coming months and years. Next one's from Angelina. What about the difference from who has Alzheimer's or inflammation from something else? Yes, that's what's so great about these. They give you 3 complementary pieces, and so you can say, is there Alzheimer's signaling? Is there inflammation? Is there neuronal damage? And with this combination, you can get a very nice look at what's going on in the brain. And then you'll know, okay, do I need to look further at this? Do I need to know if I have frontotemporal dementia? Is this likely to be Alzheimer's? Is it likely to be mixed pathology? These are really going to make huge differences in that way. So very helpful. Next one here is saying, what factors would cause false positives or false negatives for these tests? That's an excellent question. Hans, could you speak to that? Do you see?
Yeah, so that's a good question. So we do see so one of the reasons we have two p-tau tests available is that we occasionally see people that are cognitively fully normal and then have very high results on this p-tau 217. And in this kind of cases, it's obviously a false positive, and then we have ways to find out more about it. And one way is to run it on our other platform. Another way is to treat the sample with some specific things upfront. So going with the leading lab like ourselves is a complete different experience than going with something like Quest and LabCorp that are more just looking to for this from a financial standpoint.
Yeah. Angelina is asking, do these tests show positive for people without dementia for other conditions? And yes, that's exactly the point, that they're early on. So they really do give you an unprecedented look, something we haven't really had before from a blood test, so that you can see if you're headed for these problems. And it can also direct you and say, yes, this looks more like an Alzheimer related thing for your future, or this looks more like a non-Alzheimer problem, as Dr. Frykman was saying, people, for example, who have brain fog associated with COVID. So they're really helping to tell us how we can get best outcomes for everybody. Let's see. So here's another person who's saying, I was in a study during COVID. It was told 1 in 4 of my family would have it. Okay. Have many blood tests, but don't know if I was in the blood test you're referring to. Probably not. This is a new blood test. So it was a study following the book and diet. Okay. Unfortunately, I've broken the diet and path I was on. All right. Very good point. This was probably an earlier study on our RECODE trial. We did not have access to these tests, and nobody did earlier on. Now these are becoming available, and I think, again, it's a huge step forward. We are doing them in our current trial at 6 sites and working with Hans and his team, again, to get the best look at these people and look to see what happens when you go on optimal treatment. Let's see, can these components go up individually? Yes, that's exactly what we were talking about. Mentioned here mast cell activation. Hans, have you looked at people with mast cell activation in the brain?
We haven't, but that would be probably inflammatory, is my opinion. Right. So I think this would be causing high GFAP, and perhaps even then we would see start of a higher p-tau as well.
Yeah, great point. Bridget is asking if someone tests early and results are normal. Exactly. So how often do you retest? So again, I recommend 35, 40, 45, 50 if they're completely normal and you're asymptomatic. Of course, if you develop any symptoms, come in at that point and get things checked out to see what's causing the symptoms. Then once you hit 50, every 2 years, make sure, because what you want to do is you want to catch it early on so that you can now treat and reverse it, bring it back down, make sure that your cognition stays good. We should be able to keep people with good cognition for their entire lifespans. Scott is asking how to decipher the test with comorbid degenerative disease, for example, with MS or ApoE4 and MCI. Great point. So Hans, I know you've looked at a number of other comorbid pathologies. Have you looked at people who also have MS?
Yeah, so MS is particularly NFL goes up, when they, MS is usually relapsing or remitting, and when it's relapsing, then the NFL goes up very consistently. Otherwise, all the biomarker stays normal, p-tau stays normal, GFAP can go up as well with the relapse. So I would say that GFAP NFL can go up, p-tau will stay normal through the course.
Yeah. And then can you see GFAP decrease as you bring down the inflammation? For example, with long COVID, as you are resolving that inflammation, do you see a resolution in the abnormal GFAP?
Yes. So we have there's very nice data on that. So I think this is one of the big take-home points with these biomarkers, is that you want to test them at the best lab. And then you want to stick with that lab because we have our reference ranges and we do it with our methods. These are not standardized tests yet.
Yeah.
We've early on in this field, and just choose the best lab and stick with it, and then you can see that the effect that your different lifestyle changes and other things that you do will affect these biomarkers. And nothing can, this is not subjective. This is very objective measurements.
Yeah, great point. So again, the nice longitudinal follow-ups you can look at with these things. Nancy is saying, following stroke, vascular cognitive dementia, I was told this is not progressive. Is this correct? Well, the problem is that vascular dementia can be progressive because you now have a hyperthrombotic state. You have multiple vessels, and we see this fairly frequently. So again, we like to get people on an optimal treatment. Of course, there's been a lot of interest recently in sildenafil coming out of the Cleveland Clinic, but there are other things like nattokinase that can be helpful for some people. Other ways to increase nitric oxide, arterosyl HP, which supports your vascular endothelia, all of these things. So again, knowing what's going on, so helpful. And I wouldn't assume that just because there is some vascular dementia that it will not progress, because it frequently does progress. Again, getting on an active treatment. Let's see here. I've heard short of imaging the brain is not reliable. So yeah, many, many years ago, they said you could only diagnose Alzheimer's at autopsy. Then they said, no, you can do it with scans. Then they said you can do it with spinal fluid. Now what they're saying is yes. And in fact, there are groups putting together, these are the new criteria. And the blood tests will be, it's already been proposed that a high p-tau alone would be, quote, stage 1 of Alzheimer's disease. So yeah, the old idea that you can't do this without doing an autopsy or without doing scans is now no longer the case. Is that fair to say, Dr. Frykman?
Sorry, I was typing some message.
So the point that they were making is, isn't it true that you can only diagnose this problem when you do scans? And what I'm saying is that's exactly what the blood tests are replacing. They're making it so you don't have to do.
So actually the blood test is an earlier test than the
Yeah.
scan. So that's another thing that is important to say, is that even if you had a positive blood test and then a negative scan, means that if you go back to do the scan 1 or 2 years later, it's going to be positive. So we have some patients that have a negative scan and then a positive blood test, but they will convert, so to speak. They already have the amyloid pathology, and our test is more sensitive than the scan is. So in the end, why do the scan? It just gives you a tremendous amount of radiation. This is not a small amount of radiation, and it's very, very expensive. Even though Medicare covers most of it, you have a copay that is far higher than our test is.
Yeah, it's a great point. And then do these tests reduce need for neuroimaging, hippocampal MRIs, et cetera? It's a very good question. Here's the thing. Yes, it reduces the need because you can find out where you stand. However, you do get complementary information from an MRI. You can see, for example, whether you have hippocampal atrophy. You can see if you have parietal lobe atrophy, temporal lobe atrophy, and we've seen this in the past. We reported in our first trial. You can see it as it gets better as well. However, you don't absolutely have to have that anymore. So you can now follow this by following your p-tau, following your GFAP. So the answer is yes, they will reduce the need for this, even though that will give you some complementary information about atrophy. These don't tell you about atrophy, but you don't need to have that. Next one here says, Sherry says, thank you so much for this, for the work in research and treatment. Is there a point at which you would consider p-tau level, quote, out of the barn Alzheimer's pathology? So, Dr. Frykman, I mean, I think that we can't really say. We've seen people with MoCA scores of 0 get some improvement, become continent again, become speaking again, interacting again. So just dramatic improvements, but not all the way back to normal when they're that far along. But is there a p-tau level that you see where you say this is end stage and there's nothing we can do about it?
No, we don't think about it that way, but yeah, there's obviously high values that where it does correlate with the amount of amyloid plaques, so you do have to reverse it. But if you're in fact are cognitively normal, it does say a lot about your capacity to compensate for the situation that you have in your brain. So those people probably do fairly well still, but if you have severe cognitive impairment and you have a high, very high p-tau, then you're worse off. Obviously, that's so it is correlating with disease severity in some way or the other. Yes.
And this is a good point to mention BD tau, brain-derived tau. So now you are coming out with another complementary test that will now tell you, is this a more aggressive form of Alzheimer's disease, where not only do you have the high phospho-tau, but now you have total tau, which is a brain-derived tau, in this case, BD tau, in your blood as well. Maybe you could talk for a moment about your BD tau, what that is, and when that will be available.
Yeah. So BD tau is a tremendous biomarker when it comes to understanding how severe the disease is going to be. So if you have a very high BD tau and you have a very high p-tau 217, then you have a more sinister type of Alzheimer's. If BD tau is low and you only have high p-tau, then you're still at the earlier stage. So it is the prognosis is definitely going to be better. This is seems like, why would you want to do that? But you do want to know, because you do want to know how intensive your treatment is going to be.
Yeah, great point. Now, Fiona asked, can I come from Australia and get the tests? Absolutely. So you can get the tests here. If you want to get evaluated, you can come to Pacific Neuroscience Institute in LA. I work with that group. And on the other hand, if you want to just come and get the tests, you can come and get the tests. So I think it's a great idea. And again, this is so important for the future. It's not a bad idea. Come and visit the States for however long you like. Get the tests while you're here. This one here is Leonid. Can you provide examples of each of the three markers levels lowering in response to interventions? So we've seen, we're early days for those things. We've seen lowering already in some cases with p-tau. As Dr. Frykman mentioned, lowering of GFAP is associated with a lowering of inflammation, for example, in brain fog. Now, the third one, I don't know. Have you seen a lowering of NFL in any of your cases yet?
Yeah, so lowering of NFL can happen also. Many other pharma trials have shown that in other connection with, for example, tofersen, which is a drug for ALS, which is a very severe, ultimately also neurodegenerative disease. That in the tofersen trial, they could show that NFL was lowered. But honestly, if NFL is high, you have a more difficult situation. That is something that is going to be take more vigor to get past. So NFL is useful in detecting other dementias. Lowering of NFL is possible probably, but it will take more of an effort.
Yeah. Great point. Next one here is from Sam. The 2014 paper of 10 patients is very interesting. Has any other center reproduced the results? Absolutely. Also, it appears the endpoint evaluation was subjective. So, Sam, you got to read the other papers, 2016, 2018, 2022, 2023. So that was just the very first people. We had another 10, we had another 100. We had a proof of concept trial, and then another group published their proof of concept trial that got virtually identical results to ours. We're now in the midst, as I mentioned, of a randomized controlled trial at 6 sites. And we look forward to the results. We're about 2/3 of the way through recruitment in that one. So it'll be a little more time. But we'll look forward to the results from that. So please, Sam, read all of those, by the way, are freely available online. They're all posted. Cherie is saying, if you have a brain hemorrhage as a child, does that increase your chances for getting dementia? It depends on how much hemorrhage, how significant the clinical impact was. For some people, if it's relatively modest and you did well, the effect should be very, very minimal. And also, is it a subarachnoid hemorrhage? Is it an intraparenchymal hemorrhage? Is it a lobar hemorrhage? Is it a congophilic angiopathy related? For people who have a hemorrhage related to congophilic angiopathy, they should absolutely get this test because they often have similar changes with amyloid itself, which gets into the blood vessels and can allow these hemorrhages. So it depends a lot on what you're talking about, what type of hemorrhage, how significant, all those sorts of things. Next one here. is from Sarah. Any other test recommendations for someone that may be dealing with brain problems due to long COVID? A great point. And yes, says here, excellent MoCA, but low average CQ. Okay, no problem. Yes, we want to look at these different things. So please get on Recode, get on active treatment now so that you can resolve, because as I mentioned, there are a lot of similarities between what goes on with long COVID, with brain fog associated with COVID. It is increased inflammation. It is increased thrombotic tendency within the brain. So there are many of the same things. And by the way, as has been published by the epidemiologist, it increases your risk for cognitive decline associated with Alzheimer's. Next one here, let's see, test, how does it compare or complement a positive result on precivity? So talk a little bit about the relation of precivity testing to the p-tau test here.
Yeah, precivity test is similar but different. So the p-tau 217 is also included in the precivity test, which is good. We think that that those have similar sensitivity and can also detect MCI from what I've seen. So they are quite a serious lab as well. What is different here is that we do a whole host of other tests, such as GFAP and NFL, and which are not offered through the Precivity or C2N lab. So we're more complete lab testing, not only p-tau 217, but also other tests that give you a more complete picture. So Precivity is useful if it's only Alzheimer's, but as I said, you probably need these other components as well to get a more complete picture.
Yeah, great point. So we're coming up here and ending in time. So let's just, the last couple of quick ones here. Alicia says, if my CQ has me in the 90s for memory, congratulations, that's great. But only 9th percentile for executive function, and that's not menopause related. What does it indicate? Great point, Alicia. The most common reason we see for executive discord with respect to memory, good memory, poor executive function, is exposure to various toxins. And sometimes tick-borne illnesses. So those tend to give you more of a problem out in the cortex, more typically in the parietal cortex, and less in the memory-related temporal lobe, hippocampal, that sort of thing. So please get evaluated for these various toxins, because that's the common reason we see this, and it's absolutely addressable. And then Scott is asking, how closely does this test correspond to ApoE allele results? That's an excellent question. So ApoE, if you're looking at ApoE4 versus 4 negatives, this is only a risk. So, you know, your lifetime risk, if you're ApoE4 negative, about 9%, about 30% if you're heterozygous, single copy, and if you're homozygous, 2 copies, it's well above 50%, and it depends on a number of other genes. So this only tells you risk, whereas the test that we're talking about today tells you whether. Dr. Frykman's test tells you where do you stand and what's going on with your Alzheimer's signaling, with your glial response, and with your neuronal status. So they're very complementary. And again, why I think this is the most important, practically speaking, for our own cognition, this is the most important test to come along in years. So thanks so much, Dr. Hans Frykman. We really appreciate it. As I mentioned, we'll plan to come back in a couple of weeks and do a more technical. I've tried to make this very practical. You know, who needs to get it? What does it tell you? Why is it good for following? What does it do that other tests don't do? For anyone who's interested in all the technical details, who really wants to nerd out on this, please come back in a couple of weeks. And thank you again, Dr. Frykman.
Oh, thank you, Dr. Pedersen. It was really my pleasure. It was, I think, very, very good. And I hope that most people got an answer to their question. I see that there are some questions that are still unanswered, and I'm happy to stay behind a little bit to answer some of the questions by writing.
Okay, yeah, we can follow up with writing on many of these other questions, because I realize we haven't had time to go through all of them. And the others, we can certainly address some of these others at the next conference as well. So again, thanks to everybody. Thank you for the outstanding questions. And let's all try to stay sharp to 100. I think that we have a better ability to do this than we ever have before. So thanks very much.